I see many familiar faces here, so you probably know that I am Adrienne Windsor, and I'm on the board of the foundation. So we always like to start by thanking our generous sponsors, Mike and Polly Smith. And I also always say to you, we are a membership organization, so I'm going to give you a pitch tonight. How many of you are members? Oh, that's fantastic. Well, if you aren't, we are having a summer solstice on June 14th, and it will be a celebration of our new members. We'll bring them together with our board, with some of our library staff, with some of our major donors. It's a great time to get acquainted, and in this particular event, we are going to be honoring Mike and Polly Smith because they have supported, they were founders of this program, they've supported it for at least a decade. And so we decided that we would use that opportunity to honor them. And we will be inviting presenters from medicine in our backyard. So we're hoping that some of the physicians who have spoken here will come to that event as well. So if you're not a member, join, okay? And when you are a member, you hear first about the Woody Lectures and Library Live. You get all of our emails. I want to let you know that we have our last Woody Lecture this Friday and Saturday. Dr. Dasher Keltner is speaking on April 28th and 29th about the promise of and peril of power. Oh my gosh, the promise and peril of power. If we aren't in the middle of that, so it should be a great event for us. So now just a few reminders. We will have Q&A at the end of the program, so save your questions, and I will come around with the microphone so that you may ask our speaker. Remember to silence your phones. And let me now introduce this charming, wonderful speaker that we have, whose family lives about 20 miles away from where I was born, Toledo, Ohio. And when I was in high school, we used to sneak down to Toledo to drink 3-2 beer. So I have great memories of that. All right, our speaker is Dr. Sohaib Hashmi, a UCI health orthopedic surgeon who specializes in the management of cervical, thoracic, and lumbosacral spine disorders. Wow. I have one. I was in physical therapy for it this morning. They didn't tell me which of these it was. Dr. Hashmi earned his medical degree at the University of Toledo College of Medicine and Life Sciences in Toledo, Ohio. He completed a residency in orthopedic surgery at Northwestern University's Feinberg School of Medicine and McGraw Medical Center in Chicago, Illinois, followed by a fellowship in orthopedic spine surgery at the University of Maryland Medical Center in Baltimore. He also received fellowship training in orthopedic trauma at Cedars-Sinai's Medical Center in Los Angeles. This man is an expert on the topic he's going to be talking to us about tonight, and that is understanding aging and your spine. Please join me in welcoming Dr. Hashmi.
Good afternoon, good evening, everyone. I'm Sohaib Hashmi. It's my pleasure to be here, and really a pleasure to be in this community. I think this community is extremely fortunate with so many things, but especially the resources that we have, the weather that we have, and it keeps us more active and more lively than a lot of other areas in the country. I've definitely noticed that in the 2 years short time I've been here in the area. And so I'll talk about how aging and our spine go together and what it looks like and what it feels like. The lecture series is actually something that's part of a larger series of talks that I have, and hopefully we'll be able to dive into that a little bit deeper. Today's talk is really just about understanding how does our cervical spine, age, and what are the symptoms that we may have associated with. So the large majority of the lecture that I have tonight is focused on the neck. And I'll have plenty of room at the end to talk about the low back if there's questions about that and how it relates. What's interesting is that the degeneration of the neck and the low back is so different that it really deserves its own focus and time. But there are a lot of parallels, and hopefully if there's any questions about it, we can talk about it at the end. So it's my pleasure to be here. There's a few things that I want to make sure that we hit home. And one of them is that age is just a number. And truly, when we think about spine care and patient symptoms, age is just that. One of the most common questions that I have is, what are my restrictions, doc? What are the things that I can do and can't do? And hopefully by the end of the talk, we can understand if there's any restrictions at all as it relates to our spine symptoms, and the aging of our spine. The other thing that I want you to take home is really this, and it's the most important part of spine care. It's about how you feel, and it's about what the symptoms entail and what it takes to make the symptoms better. And thankfully, although I'm a spine surgeon by training, the vast majority of patients that I see don't need surgery, and we can get them feeling much, much better without surgery. Surgery is always the last option, and that's what I tell every patient, is that nowadays, especially at UCI, we have not only amazing physical therapists and acupuncturists and a chiropractic center, as well as neurotherapists. We have the Samweli Institute for Integrative Health. And that's something that as an academic facility, it offers care at an exceptional level, all under one roof. And so all of these providers are providing care related to the same diagnosis in a very meaningful way. So really how you feel is what determines how patients really have improvement. But the interesting thing about how we feel is we have to understand why we feel that way. And so getting at a diagnosis is extremely, extremely important, especially as it pertains to our spine. The diagnosis is probably the most important part of understanding not only why do we feel this way, but how can we make it better, or how can you improve the symptoms that you're having. So the short lecture that I have for you today, there are a few objectives that I hope we get to take home, and that is, one, what are the common symptoms that are related to our neck, and how can we identify them, and how can we diagnose them? And then the other things that I wanted to really show are the structural changes in the spine that we can see. We live in this era now where advanced imaging is not only all around us, but the advanced imaging and MRIs that patients receive, the report of that MRI is usually sent to the patient or faster than it's sent to the physician. And so a lot of the times the patients have the ability to see the MRI report in great detail as the radiologist reads it before I even get to fully understand and look at the images myself. And so that's one of the things that I hope in this talk we can understand is what are the changes structurally that we look at and that we get a report of once we have this imaging done. And the last thing that I hope we can try to understand is the most important, which is what is this connection? What is the connection between the age-related and degenerative changes largely and the symptoms that patients may feel? Because there is actually a big amount of interplay, but there also is a large gap in between. And how patients feel is more important than the structural changes. So I like to maybe do this in a case-by-case setting, just because I think that it allows us to understand maybe where different treatments may play a role in patients and what patients have gone through when they come to see me commonly. This is, let's say, a 57-year-old active male that has come to me complaining of shoulder pain. And it's largely a left shoulder pain, but it does go into the right shoulder at times. Interestingly, the patient doesn't have any neck pain at all. It doesn't have any symptoms related to weakness of the arm or a sciatica type of feeling of the arm or shooting pain down the arm. When we think about the low back, one of the most common symptoms that we have is shooting pain down the leg. And patients that have experienced sciatica know it. They'll never forget that type of pain, because it's actually extremely, extremely uncomfortable without a lot of great relief that you can provide it when it flares up. And interestingly, the neck sometimes does not present like that. The presentation of neck symptoms can be so different. And for this patient, it was exactly that. This patient had gone through multiple rounds of physical therapy for their shoulder, for their rotator cuff. However, no relief at the end of all of those things. And so continue to have the shoulder pain without any symptoms of neck pain, shooting pain down the arm, numbness or tingling or weakness of the arm or the fingers. And so this patient saw me as kind of a last hurrah of efforts in trying to understand, well, maybe it's not the shoulder itself if we've given it that much attention. And this patient's also had corticosteroid injections of the shoulder without any relief at all. And those injections aren't by themselves dangerous in terms of long-term effect. However, steroid injection into areas where there's ligaments like the shoulder or tendons like the shoulder can cause some damage, because that steroid by itself is not something that builds more structure of the shoulder. Rather, we know in lab studies and animal studies that the steroid over time, if it's deposited too much, can actually weaken it. And so patients often ask me, well, how many injections is too many injections? I think if the injection is working, it's okay to have a few a year. But if it's not working, then we really worry, why are we doing the injections? And so this is one of those scenarios where, unfortunately, this patient has had multiple rounds of treatment on their shoulder without any relief at all of symptoms. And so when it comes to spine and understanding how is the spine related to the symptom of shoulder pain, I think it's important to understand, well, how does the spine architecturally fit into this scenario? And I think to take a step back, the spine is made up of 7 cervical vertebrae, which are bones that are connected between themselves. So these are 7 different bones. When we think about the neck, the ribs and the area around the ribs are the thoracic vertebrae. And those vertebrae are 12 different bones and connected together. And the lumbar vertebrae, the lowest segment of the low back, is 5 vertebrae. And these 5 bones are attached in the same way, where they have attachments in the front of the spine, meaning in front of the nerves, in the discs. And we all know about disc disease and how that can change. And hopefully we can bring some clarity on that as well. But also behind the nerves, we have joints that attach these bones together. So these 7 bones in the neck are connected by motion segments. And those motion segments are discs in the front of the nerves, or in the front portion of the neck, and then the joints in the back portion of the neck. And of course, that motion is allowed by muscles. And those muscles allow for the movement of the neck, as it allows the majority of the rotation and flexion and extension of our head. And then the thoracic spine is largely rigid, meaning the ribs don't really allow for a lot of movement around that area in the spine. And the ribs are meant to protect actually the vital structures of the heart and the lungs. And so for that reason, the vertebrae around the thoracic segment doesn't move too much. And then there is the lumbar vertebrae. And the lumbar vertebrae are largely the areas that cause the vast majority of the motion in the low back. And above, between our hips and our thoracic spine, those are the motion segments that we worry about. So if we think about structurally the neck, well, how could the vertebrae themselves be causing pain into the shoulder? Well, it's probably not the vertebrae themselves or the muscles, although the muscles attach around the area of the shoulder into the neck. And sometimes those muscles that attach from this area in the spine, in the vertebrae themselves, and then go down to the level of the scapula and the clavicle, these trap muscles or rhomboid muscles that are largely in the upper neck, and also paraspinal muscles can cause some pain. Those pains are largely treated with targeted physical therapy. And so once we do targeted physical therapy of the neck muscles, it can make a huge difference in patients' care, meaning they can have a very different effect of targeted cervical range of motion and endurance and stretching than shoulder therapy. And for some patients, that's all we need, is actually a diagnosis of paraspinal muscular irritation, or myositis of the muscles, or injections if we need to. So those injections are called trigger point injections. And those trigger point injections can go into the muscles that feel the most fatigue, especially when patients say, I have a very pinpoint pain that I can point to and put a finger over on the right or left side, or even along the vertebrae. Sometimes trigger point injections of calming that muscle down with some anti-inflammatory medication can make a huge effect. And we see that those patients have actually a different course of treatment than if they just had continued shoulder treatment. And vast majority of patients do have that. They have muscular strains and sprains around the neck that need to be treated as such. So structurally, when we look at the neck, and this is a case example for this patient who's 57, we should look at a few different things. And these 3 images are lateral radiographs. So these are plain x-rays taken in 3 different settings. And you'll see that one of them says neutral down here, the other one says flexion, and then extension. And so often I get a question about, well, doc, if I had an MRI or a CT scan, how is that different, or why is an X-ray needed, a plain X-ray? Because advanced imaging like an MRI or a CT scan can give us such greater detail. What is the need for an X-ray nowadays in 2023? Well, in fact, I'll show you that the X-ray sometimes can show us different things that are extremely important structurally than an MRI can, or than a CT scan. And one of those things is that the X-ray can be done in a dynamic fashion. Dynamic meaning the patient has their head in a neutral position where they would normally hold their head, and then we take it with the patient having amount of flexion that they can tolerate comfortably and extension that they can tolerate. And we can see, is there harmonious movement in the neck, or is there some abnormal motion segment that we can detect? And so if I can point my attention here to the neutral film, you see that the square-shaped structures here are the ones that have a connection through this darker area. All of the areas that are white, those are areas that are bone. And then these dark areas and these dark areas, these are the discs. And so that is not picked up on an X-ray. So the white areas of the bone are picked up on the X-ray quite well. But all of the other structures on an X-ray are not necessarily picked up, meaning that the X-ray beams go through them. Things like air, things like cartilage, things like disc. And so what we can notice is that there's largely the square structures that line up on top of each other. But there's one segment that the structure, this square-shaped vertebrae, doesn't line up on top of this one. So if we're very careful in noticing this backside, this one is slipped. And so this is not necessarily a slipped disc, which comes to mind for a lot of patients and have some understanding of a slipped disc. This is actually a slipped vertebra. And so sometimes this type of instability is not caught on a CT or an MRI, because as we take an advanced image of a patient with a CT scan or an MRI, they're actually laying on their back, and that will reduce the slip, meaning that slip will come into a normal appearing position, and we don't even have that understanding of this pathologic slip going on. So for this patient, their pain actually may be coming from this abnormal motion segment and degeneration of that joint in a different way than the other parts of the joint, which actually seem like they're relatively aligned. And so again, strengthening the muscles around that area of the neck and giving some focus and attention to that can have a huge amount of improvement of patients with only neck pain and some structural changes. Now, by itself, these structural changes are not dangerous. And that's why it's so important to understand that aging and degeneration is largely a genetic process. So if you poll a bunch of surgeons and you say, how old do you think this patient is? Or what do you think their age is based on the x-rays? You actually almost could not tell at all. So there's patients that are 30 or 40 years of age and have x-rays that look like this. And then there's patients that are 70 or 80 or 90 and don't have any degeneration, don't have any evidence of a slip. And so largely it's genetic. Largely this is not something that is activity or quality of life or changes in their lifetime. This is a genetic disease. This is a genetic degeneration. So sometimes I use the example that the spine is like, the degeneration would be if you had a car and you drive the car, the tires have a certain amount of wear. And so the tread will wear out at a certain point. And largely it's probably related to how you drive and how many miles. The difference is with the spine, it doesn't necessarily depend on how many miles and how you drive or how you live your life. It's largely genetic. And so that's the big difference in age-related changes, is that largely it's not age, but it's genetic-related changes that are going to predict how these vertebrae take the vast amount of load. The other thing that's important to understand is in the spine, when we look at the 7 vertebrae, the large majority of changes that we see are at this segment and this segment. And so if you look at the space in between this bone and this bone, this is C2, it's kind of a weird shaped bone in that it goes up into the C1 area and then back down. And then C3, 4, 5, 6, and 7, these bones become square-shaped, kind of normal variants. The vast majority of degenerative changes happen right here for most patients. And that just shows that the vast majority of our neck and motion in terms of degeneration comes at the lower cervical segment. Thankfully, the areas in the upper cervical segment largely are not affected by degeneration and aging. And so that's good because more than 50% of our flexion and extension and rotation come from these areas. And the vast majority of patients don't have degenerative changes in those areas. And the reason it's so important is even if we are hypercritical of this disc space, and it's not as tall, so that disc has some more degeneration than maybe this one by itself. Even if this disc space is not so tall and starts to go on to what we call autofusion, it doesn't affect the large majority of range of motion. It doesn't affect the large majority of what patients can functionally do. So in that large majority of range of motion from the upper cervical segment, patients have extremely active quality of life. So sometimes I see patients with x-rays that have degeneration in multiple segments, almost to the point of autofusion, so it's bone on bone. And sometimes we hear that term bone-on-bone arthritis in our hip and our knee. Bone-on-bone arthritis can happen in the spine in the same way. The interesting thing is it's still, because of the upper cervical segment, allows us to have a great range of motion. Those patients clinically may not have any symptom at all. They're able to do all the things that they want to do in their daily life. And so again, I don't want you to take away anything except for how you feel really dictates what you can do and what's safe for your spine. Is that the large majority of what we do on a day-to-day basis and for our physical and recreational needs will not cause the advanced acceleration or degeneration of spinal segments. But it is important to understand that sometimes on even plain x-rays, we can see where there might be instability. If we look at this film, which is extension, that area actually reduces or becomes almost normal, where the squares line up, which is such a difference from the flexion, which allows a little bit more instability in that segment. So as we talked about some of the bones, the cervical vertebrae are 7 bones, like I said, and then we get down to T1 at the very bottom of the diagram, and that's the thoracic area. And the thoracic area is largely rigid. It doesn't have a lot of motion there. And sometimes what we see is there can be advanced degeneration right at that level, the lower cervical, as this is a rigid segment, and this has large majority of motion above the rigid segment. That's probably why the lower segments degenerate quicker, is there's a huge shift in the stiff spine to a mobile spine. And that transition zone is where we see the vast majority of the changes. And some of the diagram I wanted to show you is the muscles that are attached are very, very strong. And they have large areas where the tendons attach to the bones themselves. And so it's not only the bones that can cause some of the symptoms for patients, but these muscles. And so if there's an area where the muscle becomes inflamed and it's trying to hold the motion in that spinal segment, a trigger point injection can be hugely helpful. And so those patients that have a trigger point injection and have huge relief of their symptoms, we know that largely their diagnosis is paraspinal muscular pain or atrophy. And that can be treated, again, thankfully, without any need for surgery. The other thing that is extremely important in the spine is the neurologic part of it, the nerves and how they pass through the bony architecture of the spine and how it's interrelated to the muscles themselves. And so the nerves are a highway. And if we think about the skull, it would be up here. And this is the same side view, this diagram, as this, where the C2 bones is kind of weirdly oblong shaped. And in between and behind the vertebral body, so which would be right here, we have the spinal cord itself. And the spinal cord would be like the main highway. So if the main highway is the nerves traveling from the lower portion of the brain all the way down, those nerves are responsible for giving all the information down to even the lower portion of the nerves in the low back, and also all of the areas that are responsible for temperature and sensation and feeling, as well as strength of the muscles throughout our body. The interesting thing about this highway is the analogy is almost similar, where at each point of the segments of the spine, there are areas where there's exit points. And those exit points are the ones where these nerves will go to specific muscle groups and give innervation, both the feeling and also the strength to different muscle areas. And so the analogy would be sciatica, as we feel it in our low back, affecting a pinched nerve in that area, shooting pain down the leg. This is almost the exact same thing, where if you had some kind of blockage in this area of the nerve as it exits the main highway, that can cause that feeling of shooting pain down the arm or weakness in the arm. In the same analogy, weakness or a sensation of pain going down the leg in a certain distribution. Meaning it's not the whole leg or it's not the whole arm that patients feel, but it's actually the inside or the outside or the thumb or the small finger. It's a very specific distribution. And so that lets us know, well, maybe there's a pinched nerve rather than the entirety of the muscle groups or degeneration of the bones, as we saw in the x-ray, that is causing the pain. So this lets us know that, obviously, as a spine surgeon, what I worry about most is nerve health. And so the degeneration by itself is not something that's worrisome, but degeneration of any nervous architecture can be worrisome to me depending on the symptoms of the patient. And that's the most important thing, that even when we have patients that have some pinched nerve, it really depends on where they are and on the symptom cascade. If they're very mild symptoms, thankfully we can have great treatment. And this is where we think about corticosteroid injection around the nerves. And so as we've thought about the low back, and everyone is largely familiar with epidural steroid injections in the low back, sometimes patients that have a pinched nerve in a very specific area in the cervical spine can have a great effect from an epidural steroid injection in the neck. And that's something that we don't often think about. We think about epidural injections in the low back often, but the same type of treatment can be extremely helpful in the neck. And especially when we think about the advanced imaging that we have, and I'll show you some slides with MRIs, we can really target where that nerve is being pinched and how to address it appropriately. And so that's what I'll show you. Is the analogy of the highway would be if the feedback or the cars are traveling down the main highway, a blockage along an exit point really wouldn't affect the rest of the highway too much. Maybe there would be a little bit of a slowdown, but the cars and the signal going to the low back down the road or the muscle groups would largely be unaffected. And so a symptom at the exit point of that highway or one of these nerves would give a very specific type of pain. And that's exactly what our patient in case 1 had, is if we got an MRI at that same level, not only on the x-ray do we see that there was a slip of this level, but actually this bulge of the disc is happening at that level as this is degenerating. And that's causing very, very focused type of pinching of the nerve. So this image on the left side is a cross-section if you looked at me from the side. And so if you looked at me from the side just like this would be where my chin is. This would be the backside of my skull. This is incompletely visualized, but it's the lower portion of our brain. And this is that highway. This is that yellow structure. If I go back just one slide to show you, this is the spinal cord. And so from a side view, when we look at it from an MRI, it actually looks gray in this sequence. And interestingly, around the highway is this cushion. And so you can think about it's like the median of the highway, is that there is this white band in front and the white band behind. And that's the area where the cerebrospinal fluid flows. And the cerebrospinal fluid is not only a protective barrier, but it's also the nutrients for the spinal cord itself. So if the main highway has a great amount of room on the front side of it, meaning there's an excellent amount of white space here and an excellent amount of white space here, it actually doesn't have too many symptoms related to nerve health or a pinched nerve or weakness or numbness or tingling. But you can imagine if that same area, that disc herniation, is causing that highway to have complete blockage or near complete blockage of the CSF or the cushion of the nerves at that level, the symptoms can be more difficult to treat, especially in patients that have had multiple shoulder treatments and physical therapy. That's why it's such an unrelenting course with that, is that the main diagnosis is actually different for this patient. And that's what we're getting at here, is cervical radiculopathy. And so this series here now is a cross-section. So if you made a cross-section of me and then looked from my feet up, the right side would be on this side, the left side would be here, and this is actually the chin, where these are the teeth, this is the tongue, this is the back side of the skull, and these are all the muscles. And so all of these muscles, you can imagine, if there's an area where the muscle gets inflamed, sometimes even that we can pick up on the MRI. And that's extremely helpful in targeting whether the patient might benefit from a trigger point injection or physical therapy or massage. And that's why massage and chiropractic care and acupuncture can be so helpful, is that the muscles of the neck have a hugely important job in making sure that the range of motion stability of our neck is well balanced. So if we look at the muscle bulk, it's approximately 16 different muscles. And so 16 different muscles have to be balanced to really have no neck pain. And that's what the majority of patients have, is some kind of imbalance in the muscle groups. So in this MRI, we can see that largely the muscle groups look about symmetric when we look at the right side and the left side. And the muscles look largely the same color, meaning dark in their nature, with the white areas being the separation between the muscle groups. Now, if we see an area of the muscles where it's brighter or appearing more white, that can be an area of inflammation. And so all of these imaging studies can give us a lot of detail about structurally what's happening in the spine and how does it relate to a patient. Now, when I look at this gray structure, this tube, is the same as this spinal cord. And so this spinal cord now is a cross section. And this white ring of fluid that we see in the front is actually just that. It's this ring of fluid. And that disc herniation that we see here is largely affecting the left-sided exit point. So the right-sided exit point is wide open. And we can see that that nerve doesn't have any problem. But the left-sided nerve, you can see how squished it is with that disc herniation there. Over time, that disc herniation becomes what we call disc osteophyte complex, meaning it doesn't necessarily stay like a soft disc herniation, but rather just becomes basically like a bone spur. So we think about bone spurs in the knee, bone spurs in the hip. That's exactly what this is. And so the diagnosis here is cervical radiculopathy. And when you think about radiculopathy, I want you to think about that exit point of the highway. So this is not the main highway having a problem or pinching. This is just a portion of that nerve. So the main highway, their spinal cord, again from the cross section is here. The pinched nerve would be on this diagram on the right side. And this can be as a part of arthritis, as it becomes a more constant disc herniation, or it can be a disc herniation that just happens. Some patients have a car accident or trauma or an injury, and all of a sudden they feel this sudden onset of a pinched nerve. That can be from an acute disc herniation or something that happened because of some injury or event. Both things, thankfully, can be treated extremely well with targeted therapy, with targeted injection therapy, and also targeted medication. So now we have newer line medications that can really target the nerve itself. Whereas painkillers and anti-inflammatories can help the whole process, these new nerve agents can really help the nerve pain that patients feel. So that was the first case, and we'll go through the second case, but now that we're all experts kind of in the cervical spine, I think you'll find this one you guys will get much easier. It'll take me less time to even explain any of this properly. So the next patient, a little bit different symptoms, 62-year-old female that has some mild numbness in her fingers. And she has been to multiple providers. Sometimes she says she feels dizzy or off balance, but she denies any neck pain again. She doesn't have any weakness in her hands, in her feet, and no other alarming symptoms, and otherwise able to do all the things that she wants. Again, she's seen her primary care doctor. She's done physical therapy for her neck. She's done injections around the trigger point, muscle area in the neck, and hasn't had any relief. So again, if we look architecturally at the spine, we know that the cervical spine, the 7 bones, have a large majority of the motion around that area. And then the thoracic spine, again, become extremely rigid. So this patient's symptoms are a little bit different. And so there's numbness going on, long-standing. There's no shooting pain or shoulder pain. There's no pain around the muscles of the neck. And so what you can probably start to think about is, well, maybe these nerves have been pinched for a longer period of time when patients start to have numbness. And that's exactly what's happening. Is when we look at the x-ray of this patient, you can tell that there's more motion segments that are affected with degeneration. So if we look at the square-shaped structures, ideally they should be very nice and cleanly demarcated with a great amount of space in between. You can see that the level below is actually having less space in between, so the disc is becoming smaller and degenerating just like the tread on the tire would be. But also you have these big bone spurs that are forming in between. And the greatest problem in orthopedics is really cartilage regeneration. Unfortunately, the body just can't make cartilage. If we could solve that problem, I think the whole field would be totally different. In the knee and the hip, everywhere we have a joint, the body's not able to make cartilage just yet. And there's a lot of research, actually the vast majority of orthopedic research in both spine, in sports medicine, in hip and knee replacement is in cartilage regeneration. Because once we can solve that, I think our whole field will change entirely. And so because the body can't form cartilage, that's why these bone spurs form. The body is trying to make a cushion, and because it can't make cartilage, it's having this reactive formation of bone, because that's really the only thing it knows how to make. And so bone spurs are forming as the disc space is collapsing and that degeneration is happening. You can see this area is almost overlapping. And so this is that area of autofusion that we talk about, is sometimes that area will actually fuse itself together. As the bones become closer and closer together and the body tries to cushion it, it actually fuses that segment. And you can see the same thing happening at this level. So on an x-ray perspective, the degeneration is probably a little bit more. And I think this is one of the things that I hope we can take away from the talk also, is the degenerative changes that we see are not dangerous by themselves. These aren't the areas that concern me as a spine surgeon. It's only when patients have nerve changes or degeneration or structural problems with the nerves that are symptomatic that we really worry about how to treat that patient the best. So going back to the anatomy, those structural changes, again, is the stiff thoracic spine isn't able to give us much motion. And so these lower cervical areas from C4 down are the large areas that give us the motion throughout our life. And as they degenerate, those are the structural changes we see on the x-ray. So again, this patient largely doesn't have symptoms with a numbness that would be explained by the muscles or by the bone degeneration by themselves. And so for these patients, I don't say that you have to necessarily have injection therapy to try to get a hold of what the underlying problem is. Rather, I say we really need to get an MRI, especially when we've had multiple rounds of physical therapy, especially related to the neck, and the numbness and tingling is ongoing, and there's some ongoing issue with dizziness also. An MRI can be hugely helpful in understanding, well, what is the nervous system doing around these changes? And so thinking about the highway again, unfortunately the x-rays don't give us any insight into, well, what do the nerves look like? Even though we can have these osteophytes and the degeneration around that segment of the bones, we don't have any understanding, well, how do the nerves look? And that's where an MRI can be extremely helpful. Now the symptoms of numbness sometimes can be related to a exit point, meaning it could be that same exit point off of the spinal cord giving numbness only in a few areas. But sometimes when the numbness is across the entirety of the hand or major portions of the arm, it actually is not just one exit point. Then we start to think about, well, is the highway blocked in some way? And those symptoms can really point us to that. This is the MRI. And so now we can see on that same cross-sectional view from the side, so if the front is here and the chin is over here and the back side of the head would be here, these are those square-shaped structures. You can see that there's disc degeneration, but largely there's still some disc left. And so what's happening is the spinal fluid is being blocked at all three levels. So there's normal spinal fluid cushioning the spinal cord here, but you can see how much it's pushing in at each disc level as the degeneration is happening in that neck. And this can be largely causing the numbness and tingling, but interestingly, it could be causing the dizziness and the gait problem. And that's one of the symptoms that we very, very seldom can pick up without a specialist. And that's one of the things that I see most commonly in my clinic is patients have some balance difficulty, some difficulty with coordination or their fingers not feeling like they're moving the way they want. And nowadays with smartphones, most patients say, I used to ask often, is it your handwriting, do you think that's changed, or coordination, or fine motor skill difficulty in that way? And patients actually say, no, it's the texting. I just can't text the way I normally could. So I'm using my speech more than I would my thumbs or my fingers. Or having changes with, especially patients that are musicians or patients that like to sew, they feel like their coordination of their fingers is just not as sharp or as quick as it was. And very, very rarely is that picked up, meaning correlated with the spine. And how do the nerves in the highway really relate to that? Because the highway at the cervical level, the spinal cord, is responsible for all of that. Largely, it can be responsible for the fine motor skills and the coordination and balance problems that patients have. And so what we worry about the most is if patients continue to have blockage like that and balance becomes an issue, falls or near falls are the worst thing. And from a spine health perspective, not only is it the spinal cord being compressed, but hip fractures become extremely common. Other fractures around the body become extremely common, and head injuries become common when we have patients that have been dealing with falls or balance issues for a long time that have gone undiagnosed. So that is a patient in neutral. But if we look at patients and we have the capability to do dynamic MRIs, meaning some MRIs are done with a patient in different positions in that. In large majority, we don't need to do that anymore, but this is what happens in extension, meaning when the patient brings their neck back as much as possible, that actually becomes even worse than it does in a neutral position. And that's why this process takes so long, is that patients can actually adjust the position of their neck without really thinking about it and having an extreme amount of improvement in their symptoms day to day, is that they actually don't put their neck into positions that cause them a lot of difficulty without thinking about it. And so we tolerate these types of changes for a longer time just because we're able to stay as active as we want. But the vast majority of the changes can cause these subtle symptoms. And so when we think about spinal cord compression, it's a different problem than cervical radiculopathy. And radiculopathy is that exit point of the nerve having problems. Spinal cord compression, when the actual highway is being blocked, can cause all of these symptoms. And this is the most common thing that I see is these symptoms can be underdiagnosed, and it can be harder to pick them up because of their subtlety. And so when we think about this disease and this diagnosis, it's very different. Cervical myelopathy is a sick spinal cord, and this is a spinal cord that over time with degeneration has not only the degenerative changes that we see on the X-ray and the MRI with the disc changes and the bulges, but over time, because the spinal cord has vascular supply or blood supply just like our skin does and our bones do, the vascular changes actually can cause chronic changes in the spinal cord health themselves. And so those types of changes are the end stage of myelopathy. And we call this disease degenerative because largely it happens with over time use of our spine. And that, remember, is all genetic. And that is how our spines can affect our nerves. And sometimes these symptoms can be really, really difficult to tease out. So the first thing that happens is the disc degeneration, which by itself is not something dangerous. And when we see it architecturally, we can follow it and see how much, if any, correlation it has. But the longer term issues are that you have a blood supply issue, a vascular supply issue for the nerves. And that can cause recovery to be delayed, meaning that when patients have on their MRIs any issue of scarring in the spinal cord, and that can be even just a little bit of a white appearing area in the main highway, meaning that it doesn't look uniformly gray, then we worry, is there more long-standing issues? And the reality is that the patients that have long-standing issues probably have a little bit less recovery overall. So even when we have to talk about surgery, taking pressure off the spinal cord, sometimes the patients with the longest standing issues have the least amount of recovery possible, even with surgery. The good news is that now all of our studies show that any patient that has this problem and changes the symptoms, and this is the most important thing, is if there's any symptoms related to loss of dexterity or nerve damage, meaning numbness, tingling, weakness of the arm, all of these patients have improvement. We used to say for the last basically 100 years of spine surgery that the treatment for this is to prevent or halt the progression of symptoms, is that we take the pressure off the nerves and so we halt the cascade. We make a stop to that. But actually, the studies show that every patient, regardless of whether they have mild symptoms or moderate or severe, has improvement. And that's actually been the most promising thing about spine surgery in the last 5 years, is that all patients, regardless of where they are on the spectrum, once we diagnose them, they have improvement with the right treatment. And this is something, paralysis by itself will not happen in this degenerative process. And that's what I really want you to understand too, is that sometimes you get worried about the spine and degeneration. As long as patients have very mild or no symptoms, paralysis by itself in a degenerative way will not happen. The only time sometimes patients say, well, I was told by a provider, by a chiropractor, by an acupuncturist is that there could be paralysis is if there was an accident, a trauma. You can imagine that if a spinal cord doesn't have the same amount of room, it may not be able to tolerate an injury, even if it's a very low energy injury. And so that sometimes is told to patients, and it gets them very worried, obviously, about paralysis. But by itself, thankfully, that risk is very, very low. And so I don't counsel patients about paralysis by itself, but I do unfortunately also see patients in the hospital come in with a very, very low energy injury, gardening and falling and hitting their head and having a very severe neurologic injury, meaning that their nerves were pinched for so long, the blood supply had been changed for so long, that the weakness that they have of their arms and legs is very, very different than a patient that didn't have those changes. And so that's where I want to leave you, is that thankfully most degenerative processes in the cervical spine can be treated very appropriately once we have a diagnosis. And as long as patients feel really well, we don't put any restriction on what they can do. Things like yoga, things like chiropractic care are excellent for the spine itself. And as long as they don't cause you pain or restriction, it's great to continue them. So that's all I have for you. I hope there's enough room for as many questions as we can handle tonight. And we're very excited to have a new medical campus here on Jamboree. Our existing facility, the Gottschalk Plaza, has been extremely busy and outgrown its space. But not only will we have outpatient center, but it'll be an orthopedic and spine center that we do a lot of outpatient surgery at too. So thank you so much.
Thank you, Dr. Hashmi. Wow. All right, so we have lots of questions. I'll start in the front row.
Will you be having talks on other aspects of the spine, like lumbar and thoracic?
I hope so.
And you're not definite with it yet?
Oh, I'll just have to get on the program roster, on the schedule for this coming year.
Very good. Thank
Yep,
you.
absolutely.
You mentioned that yoga is good for the spine. Can you explain how it's good and how it's maybe dangerous?
Absolutely, that's a great question. So there has been so much in the way of studies and literature about yoga and spine especially, and I don't think there's another modality that's been as beneficial. And the large majority of it is that yoga and Pilates and reformer Pilates and all these things really have a balanced focus, meaning all of the muscles work in a balanced way. And that's what the spine really wants, is a balanced core with balanced back musculature. And in the neck, it's the same way, is balanced musculature in the front of the spine and in the back of the spine. And that's why it's so beneficial largely.
Good. Okay, here we go.
Along the lines of yoga, what about Tai Chi or Qigong?
It's excellent. In the same ways, except sometimes different postures that you have to hold and maintain with these different exercises can be extremely helpful in targeting these muscles. And so the muscles in the neck, these 16 or 17 different muscle groups, have a lot of interplay. And unfortunately, in our day-to-day activity, there's some muscle groups that have more of a focus, and they get us through our activities of daily living. But these other muscle groups are forgotten. They're not trained as much, and so that's why I think it can be really beneficial to do those.
Related to what you just spoke of, deep tissue massage or other massages in the same area, and then if I could, glucosamine, chondroitin, MSM, those type of elements, or others, what would your suggestion be?
A great question. So massage and deep tissue massage can be extremely helpful. One of the things that I worry about when patients say massage is helpful for the time, but the second I leave the therapist, I feel like the symptoms are back. That's when I worry that maybe we need to get to the root problem. And is it a pinched nerve along the highway that's leaving at the exit point that's causing that muscle to be aggravated? Because again, the targeted therapies can be different than just the massage by itself. Supplements like glucosamine, MSM, turmeric, all anti-inflammatory properties by themselves, unfortunately, haven't been studied to the level of evidence that we really need as a spine surgeon to say that they make a big durable change and difference. But that doesn't mean that I don't have patients that say it makes a huge difference in their symptoms. And as long as it's safe overall with your health and your primary care, especially with other medications, supplements can be extremely helpful for patients.
Chiropractic care is quite controversial in my family, some for and some against. And particularly on the cervix, where one member had a stroke after some chiropractic care of the cervix. And I've heard that's not unusual. How do you work with chiropractic care, or do you not? Do you want to comment on that?
It's a great question. So I by itself, in terms of chiropractic care, leave it very much up to the discretion of the patient and their chiropractor. And the reality is that majority of patients that I see have either dealt with a chiropractor currently or in the past and have had a very safe, appropriate relationship. The adjustments sometimes that we think about can sometimes have these extremely dangerous effects, like a stroke or a vertebral artery injury. Although they're extremely rare, adjustments can cause that risk to be a little bit higher. And I don't say that necessarily patients don't have adjustments, but that risk is certainly there. The other thing that I want patients to really understand about chiropractic care is that we have to think about the utility and the durability of the treatment, meaning that if you feel great while you're having the adjustment, does that last beyond the treatment itself or that manipulation, that moment? Do patients really have lasting relief of that? And that's the biggest issue. is that it's not causing any change in posture, it's not causing any durable change in their structure of their spine. And sometimes patients can be misled in that way, meaning that scoliosis or postural changes or degenerative changes can change, or the natural history can change with an adjustment, but that's actually not the reality, is that the changes that we see on the imaging will largely continue to progress.
Thank you.
Yeah.
Would you care to comment? I've read recently in the literature on an evolving field which may have some effect on your area, which is the regenerative medicine, injections, stem cell, et cetera.
Great question. I didn't think we'd conclude this talk without one stem cell question. It's the most commonly asked question that I have nowadays, I think. Stem cells have a huge amount of promise in the future. There's no question about it. And largely when we think about cartilage regeneration and stem cells having a regenerative role in the process, well, right now we don't have as high quality literature to support its use, especially in these diagnoses. In the future, I hope that will change. But also the reality is that nowadays, patients can pay out of pocket to have quite extensive injection therapies, and largely they're not evidence-based at this moment for these diseases. In certain areas of the orthopedic disease, meaning areas especially with tennis elbow, there actually has been great promise in stem cells, and it's changing the way we treat that disease process. For right now, in the cervical spine, there's not a lot of evidence. The evidence that we do have potentially is in my role as a trauma surgeon. In spine trauma, we actually have trials going on in where stem cells fit into patients that have had a spinal cord injury and regeneration of nerves in that capacity. And that's where large majority of stem cell research is now, both in the acute setting when patients have an injury, but also in the late. Because we know nerve regeneration does happen. We know it happens also extremely slowly, meaning when patients have a spinal cord injury, and also when we think about patients having a spine surgery, nerve regeneration, nerve health is actually probably at least a 1-year recovery process. So when we think about timeline of recovery, it's a very slow and longer one than a lot of other things that we treat. Yeah.
I had a question related to the case studies that you showed us.
Sure.
For the neck pain, or the pain that was shooting out and the man didn't realize that it was from the neck and
Right.
the hand. How were those problems resolved? Were they able to be resolved without surgery?
Yeah, absolutely. So great question. Both patients actually were treated without surgery in this case. The one patient that had shoulder pain actually had great relief from a steroid injection around that nerve. And one steroid injection was able to bring the inflammation down to a level where they were able to tolerate physical therapy. We were able to get all the muscle groups activated. And the other is gabapentin, which is a nerve agent, which can have a huge amount of relief, which that patient hadn't tried. The other thing about gabapentin is it doesn't have to be lifelong, meaning it's not a medication that we have to continue. It's really about symptomatic relief.
Would you care to comment on PRP, platelet-rich plasma?
Great question.
And I noticed somewhere, I don't know if it was in your bio or what, they mentioned orthobiologics, and is that what I'm talking, is that your reference to
Yeah.
PRP and not only stem cell, but other injections?
So it's a great question. So in its role by itself in a non-operative setting, meaning injections like steroid injections, but rather having PRP injections, overall is very limited in the spine right now as it stands. Where it does have a huge role is when we talk about surgery, and especially fusion surgery. We used to do, and I was just having a conversation before the talk we used to take hip allograft, meaning, a piece of your hip, and that piece of your hip would go in your neck, and that would cause the fusion between bones of your neck. And nowadays, orthobiologics, PRP, stem cells has taken that role entirely, meaning we don't have to harvest bone from other areas of the spine, is that we have these biologic agents that have such robust healing potential, and that allows for a quicker recovery when patients have to have surgery. So currently, as it stands, PRP is not a great solution for a lot of the conditions that I talked about now in the spine, in the cervical spine, but hopefully in the future, they may have some role.
I've got a lumbar question for you.
Sure, yeah.
Okay.
Let
Okay.
him go and then you'll be next.
Yeah, I've had x-rays, and they tell me the usual thing, bone spurs, facet, joint, something, a little scoliosis. I'd like to know how, and I'm in physical therapy, what can we expect from physical therapy as far as, getting rid of pain? Or do I have to go beyond that and get an MRI and then go to the epidural or the gabapentin? But my physical therapist right now says, just let's do the physical therapy. I'm just wondering, how much can I expect to get a recovery and get rid of the pain?
It's a great question. I think vast majority of therapy probably has to be at least 6 weeks of duration to have a really good understanding of where we are and how much it'll improve it. And what we're trying to get at, even with physical therapy, is it a muscular problem? Is it a tendinous problem or ligament problem? Those things can be changed with physical therapy in some way, meaning balanced, focused of stretching and strengthening different muscle groups can have improvement if it's a muscular related issue in diagnosis. But if it's not, and just like you mentioned, facet joint disease or arthritis around the links of the two bones in the spine and the backside of the nerves, that can be a different type of pain generator. And so what we have to understand is, does that pain, is it different and overlapping with the muscular pain? And if it is, sometimes we do offer injections to patients in that pathway. So it is exactly like you said, a pathway of understanding where the pain is coming from and the pain generator of the spine. Yeah, it's a great point. So I think that's where we have to focus on. Not only can it be the muscles around the back and the neck, but also it can be the highway of nerves. So if the nerves are pinched in some way, similarly in the neck, in the low back, they can cause a distribution of symptoms of pain that is very different. And that's why, especially in the neck, because it doesn't cause shooting pain down the arms, the patients can go months and years almost without getting the right diagnosis. And one question here too.
What do you think of the traction machines?
Great question. So traction can be extremely beneficial to patients, especially when...
I had a what was described as a humongous herniated disc, and it's totally resolved on MRI now after the traction series.
So traction actually can be really, really beneficial, and especially in patients that have degenerative disc disease that's having a pinching of the nerve. So if you think about traction, what we're doing is trying to make the space in between the discs a little bit larger. And what that does when they're having traction is patients say, well, my neck or the nerve symptoms even feel better while I'm having traction, or even low back. It can have the same effect. Or inversion tables is a form of traction, as hanging upside down. You can do it for the neck too. It probably doesn't change the natural history, meaning it probably didn't by itself cause the herniation to go back in. The vast majority of disc herniations especially are kind of like a one-way valve, meaning once the disc herniates out of where it's supposed to live, it largely can't go back in, but the body does take up that extra portion of disc, so it resolves over time on its own, or the nerves find a happy place away from that.
Two questions.
Sure.
Inversion table, how long? I do it for 10 minutes.
The inversion?
Yes.
It's a great question. So you don't want to turn blue, and the other thing is probably 5 to 10 minutes at a time is safe.
I did 10 minutes.
Yeah.
One last question. After I get shots in my spine, if that doesn't help, what's the next step?
It really depends on the diagnosis. So it's a tough question for me to answer. But it's a diagnostic modality, meaning the shots by themselves, a lot of patients think of shots as a treatment. And although they are treatment, there's therapeutic effect. For a spine surgeon, they're also a diagnostic effect. So for a spine surgeon, we're trying to figure out if that's the area that's causing the pain symptoms, then a diagnostic utility for the injection is, well, you should have some improvement of that area of pain after the injection is performed.
There's an article in the Hoag Hospital magazine recently about 2 neurosurgeons in the Spine Institute there that are using radio frequency ablation. And I assume that's to kill nerves that are bothering you. What do you think of that, and what in what context would you use it?
Great question. So that's actually in the spectrum of understanding some facet-mediated pain. And facets are these structures back here. So the spinal cord or the highway runs right in between this area. And the area in front of that is the disc. And behind of that, in the backside, is the facet joint. And the facet joint is where the two bones link up. And that's that small joint. This joint can cause degeneration and pain mediated right in that area. And so a lot of the times we use radiofrequency ablation to deaden the nerves or cause them to be a little bit less sensitive around that area of the facet. So that's correct, with very, very small. So radiofrequency ablation is a very safe method, meaning it doesn't have a very high risk of having any damaging effect outside of that area. The other good thing is that it's also done after a trial of injection usually, meaning we inject that joint, and if the diagnostic effect of that improves the patient's symptoms for a certain amount of time, then radiofrequency ablation can be a solution. Again, it's not usually performed by surgeons, usually pain management specialists that work with the spine group in most, and that's good because it's not a surgery. And it can be performed again, so it's largely risk-free. Exactly right. Yeah.
More questions? Oh, there was one, yeah, one more, yes.
Would you care to comment on the use of laser to reduce pain or any kind of healing, or LED lights or infrared sauna or anything like that?
There is actually a great amount of research into this modality of treatment. Unfortunately, I don't have a lot of experience myself in these modalities. The interesting and good thing about it is that these modalities may have a role in treatment. It's hard to understand for which diagnoses they're important, and that's what we're still trying to figure out. The other thing is they're minimally invasive and very low risk overall. Yeah.
Thank you. Thank you so much, Dr. Hashmi.
Oh, it's my pleasure. Thank you. Thanks. So much.
Our next meeting will be the last Monday in May, and the subject will be how to avoid getting skin cancer this summer. How to take care of your skin. Remember, if you're not a member, go to our website or see Kunga, join, and come to our summer solstice. We'll have wine and hors d'oeuvres and lots of fun. So happy to have you here. Thank you.